name is Jennifer Woyach. I'm a professor in the Division of Hematology at The Ohio State University. Liso-Cel was recently approved for CLL in the setting of patients with relapsed refractory disease that have received at least 2 prior therapies, including a BTK inhibitor and a BCL2 inhibitor. This is really exciting news for our CLL patients, many of whom have been interested in either participating in trials with CAR T products or being able to access these as standard of care since the last 10 years or so, when we have heard of patients with CLL achieving long-term remissions. I think that this is a really exciting paradigm shift for our patients, although it's really hard to know exactly where this is going to fit into the treatment paradigm currently, because it is actually in the same space where we just had approval in an accelerated fashion for pirtobrutinib as well. And these, of course, are 2 very different agents and paradigms for our patients, one obviously being a small molecule and the other being a cellular therapy product that requires chemotherapy, is much more intensive, and may require hospital stays for some patients. I see this being adapted primarily for younger patients who are in earlier lines of therapy and who are fit and able to tolerate a more aggressive treatment course. I think as time goes along, it's going to be really important for us to understand better who are the ones who are most likely to benefit from this treatment. As we know, the complete response rate is about 20% or so, and those are really the people that go on to have the long remission durations. People who have a partial remission in the clinical trial had about a 2-year progression-free survival, which honestly is the same as they might get from many other types of treatment. And then almost half the patients don't respond and then have had all the toxicity associated with this without any of the benefit in terms of an extended progression-free survival. So I think more work needs to be done to try to figure out a priori who are the ones who are most likely to have those complete responses. But I think in the meantime, for young fit patients who are highly motivated to do a more intensive treatment regimen, this is really an exciting thing to be able to offer to our patients. It has recently been demonstrated that there are second malignancy risk with CAR T, and this appears to be the case in multiple different malignancies, and potentially due to the viral insertion and kind of off-target effects. I think for CLL, the patients that are being considered for this type of therapy do not have a lot of other great options, and do also have a higher than average risk of secondary cancers anyway. So to me, in this patient population, the risk of secondary cancers is probably outweighed by the potential benefit. I think as we start thinking about CAR T for some patients in earlier lines of therapy, though, this is going to be a bigger deal. We have not done too much CAR T work in CLL at Ohio State, although hoping to participate in the extension trial of the Transcend study. I know that the investigators who have been working on the Transcend study are looking to see whether they can identify any clinical or biologic features that are associated with potentially long remission duration. We're also very interested in CAR T for Richter's transformation, and actually do have a clinical trial where we're looking at Liso-Cel in combination with zanubrutinib for patients with Richter's transformation as a way to extend progression-free survival and hopefully overall survival for those patients.